A very good afternoon, morning, wherever you are in the world. I'm actually still waiting for the rest of my panel. At the moment, I'm only seeing Hailiang and Sebastian. But I could already give a brief introduction about those two while we are waiting for our remaining two participants. We are having a great panel today where we are discussing the diagnosis and care for oncology and how digital health ventures are filling the gaps in there. While we are expecting Tomohiro Tada joining us from AI Medical Service, a very well-known startup from Japan, and Dr. Raghav Murali-Ganesh from CancerAid, an Australian venture. Let me at least give a brief introduction already to our already available participants. Hailiang Shi, who's the CEO and co-founder of Live to Life. Live to Life is a venture that is based in Shanghai, in China, and which is applying AI and blockchain to index and analyze and exchange all surgical innovation procedures, primarily for hospital solutions. So very warm welcome to him. And my second participant, I believe Sebastian, is joining us today from Germany, if I'm not mistaken from my last conversation. That XL has currently moved their operations primarily to Germany, considering that the lockdown had a bigger impact on the Asian countries at the moment. So a very warm good morning to Sebastian Bhakdi, who's the CEO and founder of XL. If I'm not mistaken, but I'm going to let him introduce it much more of what XL is doing. They are working in the single cell immunofluorescence cytology to basically check the label, or use biomarkers to analyze tumor cells much more efficiently, and therefore bringing a better diagnosis to cancer for patients. So let me give over the mic to my two participants at the moment, and maybe a bit more about XL and how are you delivering care. Thank you.
Thank you, Dario. Yeah, I'm to start with, I'm actually joining from Bangkok in Thailand. We split the team. I'm in our clinical research hub, and my other colleagues are in Germany indeed, yes. They're also watching. So we are covering many time zones. Yeah, at XL, as you already said, we've developed developed the latest technology for single cell cytology, and that allows us to detect cancer or cancerous cells from a simple 10 milliliter blood draw. So what we've done is we've developed this platform for rare cell isolation, detection, and characterization. And we have our first data demonstrating that this really is an excellent technology to detect tumor-derived circulating endothelial cells in prostate cancer and aid the diagnosis, the early diagnosis of prostate cancer. So it's a great screening tool in prostate cancer. We're now working on other cancers. And of course, this is really bringing cytology, cytopathology to the blood. And we have to keep in mind that the only cancer screening that really worked in the history of medicine is the Pap smear, where Papa Nicolau discovered that we can look at atypical cells from the cervix to screen for cervical cancer. And if we see these atypical cells, it's a strong indication for the presence of cancer. And this has impacted the mortality of cervical cancer tremendously over the past decades. Of course, this is all a manual process, and it is still in 2020 a manual process where cytoscreeners and cytopathologists look at cells. So if we take this to blood, it's what we are doing. We're looking for the atypical cells in blood. We need really to draw on what is possible today with modern AI image analysis to scale this to the single cell level. So that's what we're doing on a daily basis, from wet lab to AI detection and upscaling of single cell cytology in blood.
Excellent. Many thanks for the brief introduction, Sebastian. Hailiang, over to you. Probably first the same question. If you could maybe introduce what your venture is doing, therefore give a bit of also a brief introduction about yourself, considering that we have people joining this discussion this time that haven't heard when you were joining our Chinese panel around 2 months ago now, I think, covering the COVID-19 pandemic. So please introduce yourself as well.
Hello, everyone. My great honor to participate in this great event. My name is Hailiang Shi, the founding CEO for Live to Life. Live to Life is a digital surgery startup company with a mission to improve surgical outcomes and protocol adherence through digging in the real-world surgical data and the relevant software applications. And about our history, we are a very young company, startup company. I founded the company in 2017. Before that, I had been engaged in surgical system digital integration, or in other words, digital OR systems for many years. I had an idea at the time based on our existing know-how and the technologies in surgical archiving. It's like a radiology packs, ours is dedicated for surgical images and relevant data. And our software had some very handy and smart features, such as a movie around snap and infocus for surgical image video data process and editing. The huge amount of data generated every second in modern surgical workplace. So there's a great unmet need in data-driven healthcare to extract the medical insights from the actionable data. So that inspired me to start up my this venture. Why not to use our software as a very tool to detect those data first and store it in a medically structured way and build something new, for example, by applying the AI algorithm to make big impact on patient eventually. So this is our story to I founded this company. Thank you.
Excellent. Many thanks, Hailiang. Okay, and well, we had some technical issues in the beginning to have Raghav and Tomohiro joining. I also very welcome my other two panelists for this session today. So Dr. Raghav, I believe, is joining us from Australia at the moment. Dr. Raghav is the co-founder and CEO from CancerAid, a venture that is primarily focusing on the management of oncology. And Dr. Tomohiro Tada, who's joining us, I believe, from Tokyo at the moment, who's the CEO and founder from AI Medical Service, or AIM. So very warm welcome also to you two. You haven't missed much, so let me first give over probably to Tomohiro-san. If you could also give us a brief introduction about AI Medical Service and about yourself as well. Thank you.
Hi, I'm Tomohiro Tada. I'm a CEO of AI Medical Service. AI Medical Service is founded in 2017, a young company. We are focusing on artificial intelligence for endoscopy, especially for early gastric cancer and early esophageal cancer, because early gastric cancer and early esophageal cancer is hard to detect even for expert endoscopists. But I think AI will overcome this. So early gastric cancer is often overlooked by during endoscopy, but artificial intelligence surpass human being in the field of image recognition. So our product will help endoscopists to detect early gastric cancer and during endoscopy. So we are now research and developing AI system with Japanese hospitals. More than 100 hospitals are cooperating with us. So and gathering data from Tokyo University, Keio University, Cancer Institute Hospital, and Osaka International Cancer Institute. So we are gathering about 10,000, 80,000 videos of images and developing AI system. Now, thank you.
Thanks for the introduction. Dr. Raghav, I believe from your background, you're actually at a hospital at the moment from how it looks, or in a clinic. So thank you for joining us today. Same question to you, if you could also briefly introduce yourself and Cancer.
Firstly, thank you very much to the Galen growth team to having me on this conversation. I'm really excited to hear about what the other panelists are going to say, and also share our story from CancerAid. So my introduction, my name is Raghav. I'm a radiation oncologist, and yes, I'm in clinic. I just finished my clinic actually, so hopefully we won't have any patients come in, but I do a day a week of clinical practice outside my duties as CEO of CancerAid. So a little bit of introduction for what we do. So fundamentally, CancerAid is there to bridge the gap of communication between clinical care teams, sort of doctors, nurses, allied health, and patients. A lot of what we do in medicine is very transactional, very manual. Can we use technology to solve that issue? Certainly, we know that patients who come to the clinic, like this clinic, who have an understanding of their disease, an understanding of the symptoms, understanding of how to do exercise, nutrition, diet, these holistic and also sort of wider cancer survivorship issues tend to do better clinically. So we've built technology through an app as well as a coaching program to hyper-personalize that message for these patients to bridge that gap of communication. We've developed that from an in-house team. We've got a team of other medical doctors, technologists, and sort of product designers, etc. And we also launched some technology, which is the #1 cancer app in Australia, the US, and the UK, with about 25,000 people in the world using that. But the coaching program is reaping some rewards from driving that higher engagement, and we work with insurers and pharmaceuticals to deliver that. Happy to share my insights, certainly from a clinical perspective, but also from a digital health perspective. And yeah, looking forward to the discussion.
Excellent. So thanks everyone for the brief introduction. We actually have a fairly interesting panel from what I realized when I was reading through all of the startup profiles earlier. Again, just to brief myself again, we are literally having everything from the diagnosis side over to the treatment and then all the way over to the disease management side. So we literally cover the entire value chain of how we can how digital health ventures can make an impact for oncology. Probably just to give two numbers to the audience so that we actually see how strong this ecosystem of oncology ventures actually is. Considering that we are currently tracking close to 4,000 ventures in the US and in Asia Pacific, and up to 6,700 ventures across the globe. I've extracted that we have actually 240 digital health ventures in Asia Pacific alone that are focusing on oncology only. And what we're going to show in our report that will come out tomorrow, there have been invested more than $3.5 billion of venture funding into oncology ventures over the past 3 years. So it's a very interesting stats what we are seeing there actually. Okay, probably going back to Sebastian, considering that he has been quiet for quite some time now. It would be good to understand a bit, you've launched a new device recently, so I'd love to hear a bit more about your device, but also how do you see that current oncology biomarker assays can also be combined and probably also completely superseded with existing methods moving forward? So what impact can we see in the next 3 to 4 years also by using your your assays, and what methods are you using to overcome current problem statements you're seeing in the market out there, and how does XR actually has a major impact on the ecosystem you're operating in?
Yeah, thank you. So maybe to start with your second question, how new biomarkers can make inroads, first make inroads and then play a significant role in medicine. Because medicine is a very conservative discipline. We have to be aware of that, and changes don't happen overnight. But what is very clear is that if we just look at pathology, and specifically cytopathology, cytopathology has looked at cells obtained from all parts of the body, from all body liquids, from liquor, from ascites, from inflammatory liquids in the body cavity, so the pleural effusion, ascites, urine, for example. Cytopathology has never looked at the blood as such. Of course, there's hematopathology, and they look at the blood cells, but cytopathology, and I mean the pathology looking at non-blood cells, has never looked at the blood, even though, of course, the blood is in contact with cancer at the earliest stage, because cancer cannot grow without drawing nutrients from the blood. And for that purpose, early cancer starts building vessels very early on. So even cancers 1 or 2 millimeters big start building vessels, a lot of vessels if they are aggressive. And that's important if they are aggressive. If they're not aggressive, and they probably don't kill us, they also don't build vessels. So what we found in prostate cancer specifically is that these tumor vessel-derived cancerous cells, which are not blood cells, but really tumor blood vessel cells, are a very good indicator for the presence of cancer. And we start seeing this in other cancers as well. The fascinating story there is that cells from different cancers look differently. So cells from different cancer vessels look differently, and there's a lot to discover. And of course, the big challenge in pathology was that it is not easy in a routine lab where you have to look at hundreds of samples every day to look for a single cell in the blood of a single patient. That was just not feasible to do. Even though already the old pathologists and Papanicolaou in person, he wrote about the potential use of these circulating cells in cancer screening, because he was obviously very much into cytopathology. So he launched the whole cytopathology in the 50s with his book, his Atlas of Exfoliative Cytology, where he described atypical cells from the body. And it has 10 chapters. The first 4 chapters talk about cervical cancer, and that's what his breakthrough was. But in chapter 10, he actually talks about cancer-derived cells in the blood. So he knew these cells are there. There was just no technology to detect them on a routine basis, on a daily basis. And that's what we are striving to do. That's where we build our platform, which consists of various wet lab modules. And that's where we are plugging in AI to scale the single cell detection on standard laboratory slides, on slides that are familiar to pathologists. So if you want to look at it, it is in a way an incremental change that was predicted by the very old big pathologists like Papanicolaou, but it's also a disruption because we're now bringing AI into pathology, which is of course very new. Luckily, I think we are just at the right time, because just 3 years ago, the first regulatory authorities have actually issued guidances how to deal with AI in medicine. It's a very new technology, obviously, and even 5 years ago there was no way to bring that to market because there was no guidance from the FDAs of the world. And now the big FDAs are picking up and giving us guidances how to do this, how to look at this, how to make it safe for patients. So that's something that's gonna, I think, really disrupt or improve, let's say, significantly improve modern diagnostics. I don't like disruption in medicine. It sounds a bit too daring and a bit too dangerous for patient safety. So we are in the middle of this, we're riding on top of this very new wave of being able to upscale diagnostics through AI. Your first question, yes, we have recently commercialized our first device, and it's important to understand that we have this this workflow which consists of 3 modules of removal of healthy blood cells, cell separation, cell characterization, which is the cryoimmunostaining suite. This is what we have commercialized now. And the AI, the automated scanning and artificial intelligence analysis of the slides. As I said, we have commercialized the middle module, the cryoimmunostaining suite. In Singapore and Europe is where we have the first users and customers. This really enables researchers and pathologists to stain a lot more antigens per cell, so characterize single cells at a lot deeper level than before in a very simple way. And we expect that people will discover a lot of things they haven't seen before, especially cell-cell interactions, activation of the immune system, also in cancer. We know that the immune system plays a big role in cancer, and we're only starting to understand how the immune system reacts to cancer. The more you can stain while looking at the morphology of these cells on our slides, the more you will understand. This will be followed by the rollout of the other modules of our technology. Next is the separation, and there we have already labs lined up also in Germany and Singapore again, who will use this whole workflow in Singapore for detection of atypical cells in patients with liver cancer, hepatocellular carcinoma. And it will explore the use of the technology, in this case not for screening, but as a diagnostic tool during therapy, therapy follow-up. In Germany, it's yet another application, melanoma research, also very exciting. So this year, even though, of course, COVID wasn't easy to handle, this year we'll have a lot of interesting developments for us in just a few months' time.
Absolutely, no, excellent. I'm not sure if it was also clear when Helen introduced in the beginning. Please, everyone from all of our participants, please use also our Q&A session. I have tons of questions I can ask from my side, but the more questions I also receive from the audience, the more we can have this conversation much more interactive. So happy to also get your Q&As in and to channel questions whenever they're appropriate to the right person on my panel. Probably staying on the diagnosis side, Dr. Tomohiro-san, when it comes to you working with your hospitals, this one is a very different kind of way to how Dr. Sebastian is operating and working with his clients. Why does, let's say, a hospital primarily engage with you, and what are the value propositions a AI medical service is primarily bringing to the hospitals?
Thank you. So because I am already an endoscopist and writing books, and that books is a colonoscopy lecture about colonoscopy, and my book is bestseller in Japan. So I was a famous endoscopist in Japan at first, and so then we luckily at first our research and AI for gastric cancer was world's first achievement. AI for gastric cancer detection is our first achievement and accepted by Gastric Cancer Journal. So in Japan, I was I got first achievement. So and nowadays, until about among two years, we published 23 articles, mainly highly accepted, highly honored journals, GIE or then digestive endoscopy and so on. The hospitals, if hospitals research with us, and they can publish articles. So that I am a endoscopist, so I can give back for articles, by articles. So they cooperate with us because they can research with us, I think.
Excellent, many things. Fortunately, we just lost Dr. Raghav. I believe that he will come back very soon. So moving over probably a bit more towards the treatment side. Hailiang, I would love to understand a bit more of if you can share also about the work you are doing with hospitals, primarily in China, I believe, but also happy to hear whether you have already expanded your solution also into other markets. And what's the primary value proposition you're bringing to the hospitals you're working with, and how you are best supporting them basically within their own journey?
Oh, thank you. Yes, my background maybe is a little bit different with the other three gentlemen. They're more from the clinical background. I'm from the health informatics background. And our basic value proposition is providing the hospital or the surgeon, the surgical care team with data-enabled tools to annotate interoperative during the procedures. And as we all know that the so-called best practice and the medical device used during the procedures, and how you can to validate and to track and analyze the efficiency and the quality of the procedure, you need to use the real world data for the analysis. Just like the surgery is segment the human tissue and the organs, and we are the guys to segment the surgical procedure videos. And I think the most valuable tools we are providing to hospital is we provide interoperative way of annotating, the vast amount of a huge amount of the of data generated during the procedures. And we all know that the modern surgical procedures, utilizing a lot of modern imaging, surgical imaging device like 3D, 4K, and endoscopy, and even the robotic surgery. And we are providing the solution not only to annotate in real time of the procedure, but also we can store and archive the whole procedure together with the patient information or information from the EHR system with the patient's specific surgical studies, and with the surgical record, and even the surgeon specific database to track the whole information of the procedures. And our tool and the solution, the aim is to make the surgery more efficient and improve the surgical outcomes by improving the surgical qualities. And for example, like in hospital, they need also the real world evidence or data to analyze, to get some insights and how to improve our hospital's surgical care efficiency. And this is something you need really the real world surgical data to give the holistic view, and not only by the imaging side, but also from the other modality, other data source and modalities, and we are providing the integrated view, visualized view for the whole procedure informations. Yes, I think this is our value to provide to the hospital and surgical professionals.
Excellent. Maybe a follow-up question on that. Considering that in China you have lots of the 3A hospitals, 2A hospitals, and more like the rural hospitals, where do you see is the impact higher of your solution? Are you more working at the moment with more 3A hospitals, or more of the rural hospitals, of basically helping them reach out to the to more specialists, and therefore increasing the care what they can provide also to patients?
Oh yes, it's a great question. Yeah, China is a huge country, and the China divide, we classify hospital by 3 tiers, and so-called 3A hospital is the highest. And usually these are the university affiliated teaching hospitals, and of course they have a bigger demand for the tech enabled tools for the scientific research and education and teaching also. And when talking about the cancer treatment, or as we all know that the lung cancer in China is very most severe deadliest cancer in our country, and when diagnosed early, and we are more focused on the, as I mentioned, more focused on the surgical procedure less than the diagnostic. And when it is diagnosed early, thoracic surgery is often the preferred treatment method. So we are committed to using by collaborating with our strategic partners, industry partners, by utilizing our existing technology, and of course we are using machine learning and machine vision based innovative technology to improve our current platforms, and in China the medical resource is so different. And the best medical resource is in big cities like in Shanghai and Beijing. But we are very, very large country, and still there are so many county level hospitals in rural areas, and they just lack the expert doctors. Maybe they have a very relatively improved hardware or hardware or facilities. And our value proposition is actually to empower or enable the very limited expert surgeon to give care to a big area to cover a big area, to take care of more patients by utilizing the digital health and telemedicine, and also by 5G. We all know that the 5G is coming very soon. Thank you.
Thank you. Just to give a bit of stats to our users again, their cancer, so lung cancer actually, what Hailiang is talking about, accounts for roughly 20% of all cancer deaths every year. And in China, it is actually much higher compared to other countries. So we have around 3.8 million cancer patients that got newly diagnosed in 2016. They're expecting that the number is going up with increased pollution in China, and also smoking in China, which is quite a big problem, to actually increase by an additional 40% every year. So we see a huge major impact on lung cancer, and therefore also introducing novel solutions to help with the treatment of it is fairly important. Going over to Dr. Raghav. It's interesting because I think we just found out while China is moving towards 5G, hospitals in Australia still are having a bit of problem with the connection. Talking about more to the delivery of care for people who are currently coping with cancer. When we are now looking into more introducing more value-based models and pushing those forward. How do you see, can we achieve a more integrated and more an ideal care delivery model for cancer patients? And how do you see is also the difference in the particular countries you're currently operating?
Yeah, thanks, Dario. You're right. The internet, we're yet to receive the upgraded package in the hospital. Also, cancer hospitals, cancer centers tend to be in the ground floor or underneath the ground floor. So the internet connection is always a little bit poorer. To answer your question, I think it's a really, really poignant question. We are moved towards, in most sort of global healthcare systems, we are moving towards value-based care. It is not a question of if, it's a question of when. And certainly in oncology, which is the leading cause of morbidity certainly from a cost and a health economics perspective in the world, cancer patients are expensive, and the treatment of cancer is a very expensive endeavor. There's a statistic that suggests the treatment of colorectal cancer a decade ago costed $500 the numbers aren't exact, but the treatment of colorectal cancer costed $500 per week. Fast forward 10 years from now, novel advances in surgical management, medical oncology, radiation treatment, the same treatment of the same stage disease is $5,000. And the incremental benefit certainly is a 2-month overall survival advantage. Now, it's a question of ethics as to how you price that. But we live certainly in Australia, where it's a taxpayer-funded system, and there has to be a notional value to that because it's not an infinite pie. So value-based healthcare is something that will come. Is my 2 cents there. How can you draw more value from the existing paradigm of care? Costs in cancer and in other chronic illnesses are going up. So for us, the way we see the world is this concept of participatory healthcare. Can we get the patient to be more an active participant of their own healthcare and thus reduce the costs that they impose on the system? We know that patients who are more engaged, more activated in their own healthcare cost about 30% less across every chronic illness than patients who are not engaged in their care. And certainly that's true of cancer care. So the actual incremental benefit in something like cancer, which is an expensive disease, becomes even more important. The key to that engagement, for the lens that we as a company see this, is hyper personalization. If you want someone to be really engaged in their own healthcare, they need to understand the context, the information, and also be able to make those necessary changes. Cancer is a disease of the 5th, 6th, 7th decade of life. These patients have sought healthcare for many decades in one fashion. So changing this by simply giving them an app or a technology or a leaflet in a cancer hospital is not sufficient. And this is where cancer, I spoke earlier about bridging that gap of communication, but really what we're trying to do is not only educate our patients, but get them to empower them to make those behavioral changes that allow them to participate in their own healthcare. We do that using technology. It allows us to have scalable, consistent delivery of that message, but also to drive that hyper-personalization. We think a human touch is really important. I'm sitting on a panel here with technologists, and we've heard about 5G and AI, and I think it's fascinating. And certainly we employ technology. I still think there's an element here that, where healthcare still has an element of human interaction. I think the way we see the world is to say that human interaction is really important to setting up that empathy or that engagement piece, and using digital sort of means, whether it's technology like AI, to increase the cadence between those human touch points with digital check-ins to maintain engagement. The goal being engagement in someone's health, the driver of that goal being technology. And that's where costs will reduce. And then we look at the literature. We say, okay, is this proven? There's a really seminal study that came out of Memorial Sloan Kettering in 2017. It's called the BASH study, and certainly in our team, a lot of people heard of it. It might in the wider community, lots of people probably heard of this study. But what it did was randomize 2 groups of patients. Very simple study. One group of patients, standard care and treatment. The other group of patients had access to a web symptom reporting tool. So they got to report their symptoms as they went through a period of care. By doing that, they saved $19,000 per patient in healthcare costs in terms of reduced admissions, 10% reduction in admissions. They had an improvement in their satisfaction because they felt more in control of their own care. And lastly, but most importantly, they had a 30% uptick in their survival. So they lived on average 30% longer than the group that weren't. And that's the power of patient engagement. It's not just about health cost savings, but actually about patients living longer, healthier, better lives. And I think that's a really important message.
Thank you. We actually got an interesting question, and I personally love at the moment all the discussions we're having around telemedicine. Now on this panel, we actually have a fair bit of different services that can all kind of tap into the telemedicine space. So happy to hear the like your inputs from different angles to it. So we have the question that is asking around in the current circumstances of COVID-19, where patients fear clinical settings. What more can telemedicine do to assist on oncology patients more specifically? I would love to hear actually the difference between how does telepathology, so probably around what Sebastian can talk about, then the telesurgery side where Hailiang can give a bit of input, and then Dr. Raghav, how teleconsultation also with cancer specialists can have an impact on the current environment, and then basically how all those different verticals can make an impact just by introducing more telemedicine focused solutions. Happy to have anyone start. Sebastian?
Yeah, happy to comment from my perspective. So I also want to pick up where Dr. Raghav left. And I totally agree with you that it's medicine has this human element, and that what some people who, that's what we, there's a risk for getting that if you think about AI and all these great computers who can diagnose maybe, or which can diagnose maybe everything. I don't believe that, because you need the patient to be engaged. That's very correct. And that's also where we come from a very different angle, but with the same goal in a way. The patients need to be able to need to be empowered to take decisions. The earlier the better, especially when it comes to cancer, because we know if you diagnose it early, you can probably cure it. If you diagnose it too late, you can't. That's why we are really focused on screening, and that's why we want to leverage all the technology we can leverage onto finding cancer early and finding every cancer early, because what we see is that cancers shed atypical cells into the blood early. That is very clear. If we find them, there's a red flag in the body. We need to find out what's going on. I'm not saying that next year we will be able to screen for 200 cancers, but it is very realistic that in a few years we will be able to say a lot from one atypical cell we find in the blood about the state of the patient's body. That is, of course, where then the telepathology comes in, because in the ideal world, we don't want to make this accessible only for the high-income countries, but for everybody, because if we don't help everybody, that we see this, the whole migration in the world, all the upheaval we have, it's based on economic differences, which are too large, and economic differences are also triggered by inequalities in health. So we need to work towards more equality in health, exactly what Hailiang Shi in China is doing as well, because we need to provide people with equality, equal access to healthcare. Now, if we bring in telepathology, and that is not about replacing pathologists, that is kind of superpowering pathologists, because it takes a lot of time to find that cell, but it takes a few seconds to decide if the cell is atypical or not. That's what they do every day in cervical pap smears, but there are more cells of this, it's easier to find. So if AI can help us to identify that this is probably an atypical cell, and we scan the slide, we send the data to the cloud, or alternatively to a workstation in the hospital, secured from the cloud, depending on the legislation, depending on preferences. And the pathologist can then draw on this resource to help a lot more people than he could in a normal day's work. Then in the coming epidemics, pandemics, whatever you want, this will always be a very strong asset to guarantee access to healthcare. As are, of course, simple blood tests, because taking blood it's considered non-invasive, and it requires a very short touch point with the healthcare system.
Thank you. Dr. Raghav, Hailiang, any of you would like to come more from a different telemedicine point of view?
Yes, I agree with Sebastian very much, and great comments. And from my own perspective, I think the future of health and care, I would like to use a very simple word. Now is, previous and now the patient go to hospital, see a doctor, right? See doctor. But in the future, I would like to see is the doctor to see the patient. Still there are many patients, right? They cannot move, right? For the orthopedic surgery patient, they cannot move. And I think the pandemic, the COVID-19 will speed up. Will actually speed up the trend to make the doctor to see the patient, because nowadays we have the technology, right? We have 5G, we have the cloud, we have the digital health, we have AI, and it is exactly to make the big amount of the common patient to enjoy a high quality of health and care, and for surgery point of view, and this is not only for the procedure during the OR inside of the operating room. This is actually about the whole a perioperative solution, right? Before the surgery, how can you be more prepared for surgery? And how can you transmit? You do not need to necessarily go to hospital to make all the way down to travel 2,000 kilometers to Beijing to see an expert doctor. You can actually to transmit your EMR or EHR, your pathology findings beforehand to the doctor, to the expert. And also after the surgery, and we for example, we are upgrading our software for the wound management. After the surgery, and the patient can easily use his mobile phone to take a photo of his wounds and upload it to our cloud. And then his doctor can see it and can make a better decision. So during the pandemic, as far as we know, a lot of our surgery are canceled, right? The so-called elective surgery are canceled. But you still, you can utilize the networking and the telecommunication and the modern technology to maintain a close tie between your hospital, your doctor, right? By sharing your EHR, your EMR, your newest information. So I think, yeah, in one word, in the future of health and care, also including surgery, let's allow the doctor to see you. And if the doctor cannot see you, let's allow him by using robotic to take care of you, right? Now there's a so-called telemedicine enabled telesurgery that the expert surgeon perform a surgery 2,000 kilometers away from another country. This is realities. So this is exactly, we are utilizing telemedicine, telehealth to empower the healthcare professionals and for the better health and care. Thank you.
Thank you, Hailiang. Dr. Raghav, you would like to add?
Yeah, so I just want to touch on the points that Sebastian and Hailiang made. Completely agree with them. You know, COVID in some ways from a digital health perspective supercharged the adoption of technology in hospitals. Just anecdotally in our own practice and in the clinic that we do here, one of the largest cancer hospitals in Sydney, we did not expect COVID to hit, and all of a sudden, these new rules were imposed on us where we were not allowed to see patients. Cancer patients, certainly immunocompromised, generally have a lower threshold from a risk perspective from COVID, you know, because of increased susceptibility. So very stringent rules around face-to-face interactions were introduced. And we suddenly, without very much change management, were thrust into this telemedicine landscape. We've managed 14 weeks. It has driven efficiency up in our clinics. We are able to see more patients. Yes, we lose some of that interaction and that, you know, some part of the clinical ability is to examine a patient, and you lose a little bit of that through the telemedicine. But what you do gain is the increased volume of patients, and that's a great thing. The other thing that I just want to make a comment on outside of the top comments that Hailiang and Sebastian made is change management is often the hardest thing. Medicine is a very conservative industry, and changing people's way they do things for many years is difficult. One of the things that COVID has done is allowed that change management. And I think more people always talk about commercialization and healthcare being difficult. I almost say just as hard as that in hospitals certainly is permission and that ability to alter the culture of the incumbent processes and altering that to bring in something new and novel, certainly without the strength of the evidence from a historical practice. What we are seeing now is more and more literature show that these telemedicine practices are reducing the waste of inappropriate hospital care. And that again goes back to that point about driving costs lower, but also increasing the value of a quaternary level. Your value out of the quaternary referral center is much higher. And I think that's really important and goes to the point that Hailiang was making about, you know, the tyranny of distance. If someone is 2,000 kilometers away from a specialist center who are excellent in one particular operation, they can see more patients and spread that expertise to a wider group of deserved patients, or needing patients, not deserved, I should say.
Tomohiro-san, have you also been more exposed to telemedicine solutions for your own, in your own work? I remember when we had the kickoff call, you and Hailiang were actually fairly interested in the solution of one another. Have you been now more exposed recently to that your hospital clients were asking for a more telemedicine type of solution as well?
In Japan, telemedicine, online diagnosis is now prevailing rapidly. So I heard from another startups with COVID-19 in Japan, online doctors meeting, online doctor meeting is scaled up 10 times by before COVID-19. So and all the Japanese conference conference is canceled and goes virtual by Zoom meeting. So that's I'm hearing in Japan, Tokyo.
Excellent. Hailiang, probably then the same question to you coming back. Since I recall that we had this nice conversation between one another during our kickoff call from the cohort, and I understood that you and Dr. Tomohiro had a bit of a discussion after this. Can you elaborate what was the interest in one another and how you can combine also like a venture kind of partnership? So moving towards the partnerships, what are you seeing there? What are the potentials you're seeing in one another?
Oh yes, I had a very nice Zoom conversation with Tomohiro from AIM. Yeah, very nice, and I'm very impressed by their development and the findings and the research. And as I mentioned, they are more focused on the diagnostic, and we are more focused on the procedure analysis. And so I mean, if we can combine each other's power or strengths, that would be fantastic. I mean, as a startup, yeah, we are small, early stage startup. We have our very specific niche marketing area, right? We are specialized doing this, like the background image I put in. We are specialized infopin, the real world surgical data. So we do not necessarily do everything, right? And if they are very matured, very good matured existing technology and solution, why not to work together? It can be a university, right? Shanghai Communication University, we are already working together because they are very good at the nodule or the lung cancer nodule detection by the CT imaging AI assisted scanning. And my imagination is the potential collaboration area with a company like Tomohiro is because for surgery, we are more focused on the real-time intraoperative. You know, time is very critical for us, right? Because the surgeon need to make very quick decision during the emergency surgery and during the, you know, and if we can provide a solution or way, or it can be AI back the solution or AI back the technology to detect the lesion in real time during the lung cancer, for example, lung cancer segmentary procedure, because there are many different organs and the tissues and arteries, veins. It's very difficult for surgeon, especially young surgeon, to identify. If we can utilize the machine vision to help them to detect it, and during the procedures, that would be very promising, very interesting. So as I mentioned, if we can integrate the real-time diagnostic technique into our perioperative surgical data platform, that is very interesting for me. Yeah, I look forward to find out more and to collaborate with the industry partners It can be a tech company like AIM. It can be a university. It can be a medical device company like we are working together with some. Thank you.
Probably one very last question, because I know that we are running out of time. Probably in one or two, or maximum 2 sentences, could you give a bit of an overview where, under the impact of the new normal, how have you reimagined your next 24 months of your own company? Probably just to give a brief overview, everything is on steroids now. So how do you see your company now evolving in the next 24 months? Anyone can start. Sebastian, probably.
That's a good question. So it's obviously very difficult to plan. So what we've reimagined is that we will have to work virtually as a team, which can be challenging, but we're actually managing very well, distributed over continents. So we're emphasizing that with every team member that this virtual work together is the new normal for the time being. At the same time, we're seeing in certain regions that there is significant additional funding for R&D. So when we roll out the modules of our technology, we see that as an opportunity to go into the market, to accelerate going to market.
My turn. Hello, my turn. All right.
How are your next 24 months, Tomohiro-san?
Okay. Yeah, in 24 months, I hope to see. Yeah, we have developed very nice tools for doctors to infopin, to annotate the live surgical procedure data, and in 24 months we will see. I hope to see it can be really smart. It is a really smart infopins, and it can automatically infopin annotate the key image phrase, and while teaching the machine to automatic learning, and we then apply to the most valuable application or scenario. It can be a lung cancer surgery. It can be a prostate cancer surgery. And we will find out by collaborating with our strategic industry partners. Thank you.
Thank you.
Yeah. So, thank you. Because our company is in research and developing phase, so we are not so suffering from COVID-19. Next year, we'll launch our first product for gastric cancer classification in Japan and also in Singapore.
Thank you. And unfortunately, we have lost Dr. Raghav, but I would love to thank my panelists. We could have wrote this panel much longer. I know everyone has lots of things to say, but many thanks for joining us during this very first panel to kick off our little virtual summit. So many thanks for you joining us, and I wish you a great afternoon.